Sure, go ahead.
Yes. So good evening, everyone. We're so pleased to see you, and I'm sure that we will have more join. We know that this is the dinner hour, but you know it's the best time for us to get together on Zoom. We certainly don't want our town hall to go too much past 8:30. So very good to see you all on Zoom here tonight. And as you know, this is the Health Association of African Canadians Organ Donation Town Hall. We are delighted that we have with us some really capable people whose work it is to discuss, to promote organ donation, and also who can help us understand the legislation and understand opportunities that are out there for African Nova Scotians, people of African ancestry, to be involved in the work of organ donation, and also to be involved in the work of policy, public education, and also potentially even a TV program. I'm just going to say that as a little bit of a teaser there. So hopefully you'll stick around and be able to hear more about that later. I am Sharon Davis-Murdoch, co-president and founding member of the Health Association of African Canadians, and very happy tonight to be sharing hosting responsibilities with my colleague and former or past co-president of HAAC, and that would be Dr. David Haase. So over to you.
Sorry about that. Hi, everyone. Good evening. Good to see you all. So let's just check in with Steve. Are you hearing us now on your phone?
Yes, I can hear you on the phone.
All right. So a little bit of an echo because of that, but we'll keep going. That sounds good. So it's my pleasure to be hosting this along with Sharon. And as she told you, I'm a past co-president of HAAC, retired physician, ID, and internal medicine. And basically, we're going to go through and talk about organ donation. And Sharon, do you want me to just keep on going?
I do.
Yes, all right. So our first speaker is Dr. Stephen Bede, who is a medical director of the organ donation.
Oh, sorry. I thought you were going to talk about the Wordle.
Oh, do you want me to do that first?
Yes.
See, I'm rushing because of time.
Okay,
All
no,
right.
let's not rush. Let's do this.
Let's do that first. So I have a little fun something for us to do here. Let me share my screen. Okay, can everybody see that?
Yes.
Okay. So at the top of the screen, so you need to get your cell phones out. Stephen, I don't know how you're going to manage, but you need to get your cell phones out. We just want to know who is here. We're going to just see who is here on the call with us right now. Go to www.menti.com. You see it at the top of the screen. And there's a code at the top of the screen there that you can just put in. And I'm not seeing it, so you'll need to.
5844. Yeah.
It's 1607-5844.
Right.
So put that in and then put submit, and you will see the first question. So these are completely anonymous. No one is going to be able to tell it's you. And so basically the first question is, where are you geographically located? So just go ahead and tell us where you are and submit as soon as you do. So we'll wait until you're all done. Take a few minutes. All right, give it a few more seconds, see if anybody else wants to input. All right, let's see. So the larger the letters, the more people are from that place. So looks like we have quite a few from Toronto and Ontario. Somebody GTA, so that's, yeah, there as well. Okay, let us move on. Here is the next one. So again, stay in the same place. You see the questions will change as you go through, so just keep your phone on that same place. And here it is now, what is your age range? And I will give you a few minutes to answer that as well. Just put in your age range and then submit. Okay, let's see. All right. So there are the ranges of us who are on the call. And we'll move to the next one. What you regard as your racial identity. And we'll see. All right. Okay. So that was just to kind of get us a little bit of who is here on the call. And it's great to see we have 24 people in all. That's great. So we're going to move ahead with our first presentation. And Dr. Stephen Bede is the medical director of the organ donation program for the Nova Scotia Health here in Nova Scotia. Right. And Steve, I'm going to ask you to introduce yourself and then you go ahead with your presentation.
Could I just frame this though a little bit, yeah. Dr. David, because we want to ensure that that our participants are aware of kind of the reason or the rationale for this evening's engagement. We want to certainly have Dr. Bede talk to us about the legislation that was passed in January, but I think framing it in the context of understanding the legislation within the lens or the cultural specificity of people of African ancestry is important. We need to recognize before we go any further that there is a legitimate mistrust of the health system by people of African ancestry. We've seen this, and HAAC has been working to address this from the time of our establishment, because there has been a history and lived reality that is impacted by systemic racism. And that we have, in fact, historical examples around organ donation, fear of that, concern among people of African ancestry in the United States and across the African diaspora. And so people have been wary of organ donation. We know, for example, that in the United States, African Americans make up a very low rate of those people who donate organs. And there's been a fair bit of research about why that might be in the United States. And in some cases, there are a lot of myths about organ donation, concern that that we may be used as guinea pigs. It's a familiar concern, mistrust of the health system that we've heard about with respect to COVID-19 vaccines as well. So it's important to understand that we are validating a couple of realities here, that there is mistrust of the health system. There is an opportunity to understand more about this legislation, but there has been, unfortunately, not enough culturally specific information about this legislation for our people. So tonight we are doing this town hall with that in mind, and we're responding in that way. And interestingly, the irony is that we are aware, and Dr. Bede and I'm sure others of our presenters will tell us, that for many of our people who are on the waiting list for organ donations, they are really looking forward to the gift of life, organs from our people, where you don't have to have necessarily an organ from a Black person to a Black person, but it can sometimes be a better match. And I'm no clinician, but we'll hear about that, I'm sure. So I wanted to frame that for this town hall, and certainly have Dr. Bede introduce himself and talk about the legislation. But I want to acknowledge that reality, and a number of the people on this call are aware of that and have expressed that. So HAAC has responded. Fair enough? Thank you so
Sharon.
much.
That's great.
Okay. So Dr. Bede, over to you.
You're muted. We can't hear you.
Oh, I'm going to try and do this. Can you hear me now?
Yes.
It's working on the, I think you should turn off your phone because it's getting an echo. So your volume is working through the Zoom now, I think.
Is that better?
It is.
Yes.
Yeah, we can hear you loud. And
my 14-year-old could probably have figured this out for me, but here I am. Thank you very much for the invitation. I'm really grateful to have the chance to talk to your community. I'm going to try and go through a lot of material fairly quickly, but the take-home message is that when we brought this in, I'm going to show a little slide presentation if I could. Can I share screen now? I'm going to try and...
Yes, you should be able to share.
Okay. Not sure I can see if it's coming up. The screen that I have now, are you seeing it?
No, we're not.
I can't hear you. Are you seeing
no,
the
we're not seeing it right now.
Okay.
So you click share
sure
screen.
The explanation for that is. I will see if I can make this work.
Okay.
In any case, as I work on that, if this is not going to work for technical reasons, then I can certainly speak to this topic off the top of my head.
Okay.
You can forward the presentation to David or Lydia, who can share it.
Okay. Well, I'm happy to do that.
Or Carla.
Thank you.
Yeah, one of us. Yeah.
All right. Why don't I try and do that?
You want to send it to me, and then I can change the slides for you.
Okay. I will try and send that for you right now.
Okay.
In any case, as we get ready to do this, what I would like to highlight is my role is as the medical director for the provincial organ tissue donation program. I've been involved with this for a long time. And my role as the medical director is to serve as a consultant, a medical consultant, but I'm really working with a large team of people who have been extremely instrumental in the success that we've had. In spite of the fact that we've had some success, I really see that we're falling short. And so in my role as the medical director, I've been trying to work on making this program better. What we found over the last 15 or 20 years is that our donation rates in Nova Scotia had turned out to be reasonably good relative to our contemporaries in other provinces, but much, much below what the most successful programs in the country and the world had, and also much below what our patients need, because no matter how good our donation rates were, there were people waiting. I'm not sure why this isn't working, Dave. It's very frustrating, but it is what it is. In any case, as we work through the challenge of making our system better, the Premier came to us in August of 2018 and highlighted his desire to try and make things better. So in order to understand why that was necessary, we should probably talk for a few seconds about why I think donation is worth it. I'm going to assume that we're not going to be able to get the slides to you, so I'll just highlight a few things. Our donation rate in Canada is somewhere around 21 or 22 donors per million. So to put that in perspective, in Nova Scotia, which has one of the better donation rates in the entire country, we're talking about roughly 20 people in the entire province over the whole year who go on to be donors. While ballpark 300 people in our region are awaiting solid organ transplants. So there's a huge need. And the people who are awaiting are living tough lives. They're alive, but living with renal failure or with terrible lung disease or liver disease is really tough. So even though they're alive, we want to make their life better. And transplant is not a scientific experiment anymore. It works. It's the best treatment for people with end organ failure. So when we think about donation, we need to think about who it's benefiting. And clearly the recipient is benefiting. Somebody that is at risk of dying is given a second chance at life. Everybody thinks about that. One of the points that I'd like to make, and one of the reasons that I got involved with this, is because I'm an ICU physician and I'm taking care of somebody in the unit. I've gotten to meet their family. I'm meeting them on the worst days of their life. And there's nothing we can do for them in many cases if somebody suffered a terrible brain injury. But the idea that in the death of a loved one, there might be some positive is really an important part of the decision for some of these people. And I didn't realize it. I didn't get it. But we have a gift of life celebration where people who've made the decision to donate get together and we commemorate that, and they get together and they celebrate the life of the loved one that donated. And that's when I realized that for the people who've made the decision to donate, the fact that something positive came out of a terrible circumstance helped them through their grief. It helped them craft a legacy for their loved one. It gave them a little bit of something positive. And I've often heard stories about how my dad was the guy that would always shovel your driveway, or he'd help you, or he was coaching the local sports team or whatever. He was that guy. And so it makes sense that in his death, he would want to help people. So the reason that I got really involved with this was not because recipients are benefiting. That's hugely important and obvious, but I don't know who they are. They're not my patients. But the donor and the donor family are, and that's important. From a system point of view, supporting donation is healthcare dollars well spent. Dialysis costs a lot of money, and giving them better treatment with a kidney transplant, for example, avoids dialysis, and ballpark $300,000 of cost avoidance for each kidney donated. So when we talk about supporting donation, the passion that I have for it is that it's the right thing for a donor family that I can't offer anything else to, and it'll help them through their grief. It's hugely beneficial to people who are on the transplant list, and it's good from a system point of view. But in spite of all that, what we found was that our donation numbers had relatively plateaued. Other places in the country and around the world could be successful. The Premier approached us about new legislation, including deemed consent, and that was passed in April of 2019 and proclaimed in January. So that's the reason we've really got together today. And one of the commitments we made when we met with the Premier was that there have been historically marginalized communities in Nova Scotia that we knew might not know about this new law. It was a big change, and we made a commitment to try and communicate as best we can. Frankly, I think we've done a job that's not as good as we could or should be. And so the opportunity to connect with your community through this is something I welcome with open arms. I've worked with Dr. Robin Urquhart, who has met with a variety of communities across the province. And we've had the chance to start a conversation with the African Canadian community. And the mistrust issues that Sharon had highlighted are things we've certainly heard. And my attempt to discuss this with you in this forum or any other opportunity in the future is our effort to say, I'm concerned that we haven't done this as well as we could or should, and I'm open to your suggestions on how we can make that better. We've also reached out to the First Nations community, to rural communities, to the LGBTQ community, and so on. I know that this is a big change, and communicating with people and answering their questions is an important thing to do. But why did we do the new law? Well, obviously, the Premier was concerned, and his argument was, why should perfectly good organs be buried when people are dying? He didn't understand the issue, but that's what drove it for him. We know in Nova Scotia from surveys that about 95% of the population have said they support organ donation, and our organ donor registry is at about 53%. So there's a big gap. So one of the reasons for the legislation was to acknowledge that there's a big gap between what people say and what they've gotten around to doing. And this sends a message that donation is good. We know when we deal with families, the donation opportunities in the context of a crisis. And families are scared, they're exhausted, and they don't think clearly in that setting. And so asking people to think about this decision in advance is one of the strongest pleas we can make, because under the new law, everybody that is medically suitable is considered to be a donor unless they are opting out. And what that means in practical terms is that there is a registry with MSI, with the health department, and you can register your intent to opt out officially in the database. But the other thing we've made a commitment to do is talk to families in the time of crisis. And if somebody did not register their intent to opt out, so it's not officially in a registry somewhere, but their family know that they do not want this to happen, we consider that to be opting out. We will have a family dialogue, but the question we will ask is, what were the last known wishes of your loved one? And if nobody knows, then we would assume that they would be a donor. But if somebody were to say, my dad didn't want that, then that counts as opting out. So our strongest plea is to think about this, become informed, discuss it with whoever you need to be able to make a decision, and make sure your circle are aware of it, so that if this ever were to present itself, the conversation we have with your family would clarify what your wishes were. That's an important thing to understand, because the law says that you're a donor unless you opt out. So that's how you would opt out, by either officially doing it or by having that conversation with your loved one. And it doesn't apply to everybody. If you're under 19, if you don't have decision-making capacity, if you're a new resident in Nova Scotia, those are people the law does not apply to. But if you were in that category and you wanted to be a donor, you could register that. So I should take a couple of seconds and point out a couple of common misconceptions, because many people say they don't want to be a donor, but when you drill down, they don't want to be a donor, sometimes because reasons that we need to clarify. For example, if I say I'm going to be a donor, then the team won't try as hard to save my life. They want a donor. They don't want to help me when I'm really sick because they want somebody to be saved my organs. I have heard that. I have to acknowledge I've heard it, but I've lived at the bedside for decades. I have never seen that. I think that that's something we have to acknowledge is a concern, address it by saying that that's just not what we're doing at the bedside. My life is focused on trying to make people better, not to get more organs. But if you have died, you've had a terrible brain injury, could you help somebody else by being a donor? Of course, we should talk about that. Another thing, how do they know I'm really dead? Maybe I'm not really dead. Maybe I just have a really terrible injury and they don't want to spend enough time for me to get better. That is a legitimate question because diagnosing neurological death, which is what you have to be a donor, is actually a fairly complex clinical thing. And the rules to diagnose neurological death are much, much more stringent, believe it or not, than to diagnose death in a general sense. If I was one day out of medical school, I might be called to the floor to diagnose somebody as dead, to declare them dead. In order to diagnose neurological death, it has to be two specialists. So they have to be experienced, they have to be specialists, they can't be on the educational roster. There are a large number of medical conditions that have to be ruled out that can mimic brain death. A very complete neurological examination has to be completed by both. There has to be a test called the apnea test, which confirms that even if you're not connected to a ventilator, you do not breathe on your own. And if any or of those cannot be completed, then you have to do an additional layer of testing. So when people say, how do they know I'm really dead? Well, it's a pretty complete process. What if people say, well, I don't think you're dead if your brain is dead. I think you're dead when your heart stops, not when your brain is dead. There have been a couple of court cases in various parts of the country, most recently one in Ontario, where this issue has been discussed with expert medical witnesses and extensive review. And the courts have quite clearly said that the medical standard for death is met by these criteria. When you meet criteria for neurological death, you are dead by medical criteria, legal criteria. So I've heard it. A common one, my religion does not allow donation. All of the major religions support donation or the right of an individual who's a member of that faith to make that decision for themselves. There is some issue in the Islamic community. We've actually had several meetings with the imam and with the Muslim community and with ISANs to talk about these issues. There is some interpretation of the Quran. If I save one life, I've saved all of humanity, or the contrary, thou cannot desecrate a body after death. So there's been some confusion in the Islamic community, some concerns depending on various faith groups, but there have been several fatwas passed by Muslim clerics, leaders of the faith, and the local imams here have been strongly supportive of the donation. Now, there are specific issues around rituals at death that we need to respect, but we've had that conversation, but it's very important. Faith is hugely important to most people, and it's especially important at death. So we have to acknowledge that. Another one we hear, my organs are going to go to the rich or to the influential or to the powerful, or my organs are going to be sold. I've certainly heard all of those things. I've done some work internationally. I've been in China, in the Middle East, Pakistan, where if you are wealthy, it is not difficult to buy an organ. It's terrible. It's against the law, but it can happen. So we have to acknowledge that transplant tourism does exist in the world. It does not exist in Canada, in Nova Scotia. I've heard it. That is not what's going to happen in Nova Scotia. As for the rich and the influential, the decision around who gets an organ that is donated is very clearly defined. And the number one reason, medical, meaning the sickest person gets the organ if they're a match. If you're very, very sick, but your blood groups don't match up or whatever, then you wouldn't get the organ. But if the organ would fit and it's a life-saving situation, the sickest patient gets the organ, irrespective. If you are not in that situation, for example, kidneys, there's many people on a kidney wait list for years. And the decision around who actually gets a kidney that is offered, to be honest, I'm on the donation side and I have a sense of what the transplant colleagues do, but a transplanter would be a much better person to answer that. But the clinical match should be as good as possible. And then there's other factors, like, for example, if everything else looks equal, who's been waiting the longest time. But it is an objective system. It's regularly reviewed. There are defined criteria. And so having an organ go to the rich or the influential because they're rich or influential in itself does not happen in my experience. No, I've said more than enough. I'm happy to stop at that point. Apologize that I couldn't get you my slides, but I'll leave it at that and answer any questions that come up. And if you don't mind, I'd be quite happy, if not, to just listen to your conversation.
Well, I know that Dr. David is going to jump in here and kind of moderate or facilitate questions and comments. I would just like to, before handing it over to him and to our participants, just want to make the point. We really appreciate your coming and speaking very specifically to many of those myths that we have heard, Dr. Bean, in our communities and the literature. Again, a lot of this literature comes from the United States that talks about African American attitudes. Our work at HAAC is to have more and more literature that talks about our African Nova Scotian experience, and so that's part of it. And another part is, of course, the engagement of our people in policy and decision making. So when this legislation came about and the opt-out piece, which differentiates this from the earlier legislation, was there, what we heard was not that part. We did not understand what opting out actually meant, and it's very important that that we hear from you what it actually means, but also that there is some decision making on our part, and there is some opportunity, or there was some opportunity to engage us in specific ways that wasn't taken. Has nothing to do with your efforts, but it has to do with a reality of the system. And this happens over and over again. So here we are. And with that in mind, I dare say that that Dr. David will invite our participants to ask questions, make your case, make your point. I will say this very quickly. Sister Delvina Bernard, was the one who brought to our attention that this was being talked about in African Nova Scotian circles, because there had been some concern that people didn't understand what this legislation was, and also a fair amount of mistrust. And so, we are responding very clearly to her concerns, but also to the concerns of many. So having said all of that, over to you, David.
Thank you, Sharon. So, Stephen, Dr. Bede, thank you very much for that. That was really good, even though your slides weren't up. And what we do now is ask the participants here for questions or comments. What might be easiest is if you go to, at the bottom of your screen, there's a little icon called reactions. and you can raise a hand. Yes, George, you're the first. Thank you. Go ahead.
Body parts?
Sorry, you need to repeat again. We didn't hear the first part.
You hear me? Hello? Hello?
Yes, we can hear you now. Can you hear us?
Yes, I can.
Okay, go ahead, please.
Is there an age limit for donating your body parts?
Well, that's a great question. The donation decision falls under two categories: organ donation, which I have talked about. The other is tissue donation. Tissue donation would be corneas, bone, skin, heart valves, things like that. And there's a huge need for tissue. There is an age limit for tissue. If you are 71, then you would be too old to donate tissue. With organ donation, there is no upper limit, although as we get older, the chance of us having medical troubles that would make the quality of the organ an issue is part of our decision. Having said that, there have been 90-year-olds who have donated livers. We had a 79-year-old woman who was a very fit woman who had a big giant stroke and bled into her brain, and she donated everything except her heart. So we would make an assessment based on your medical conditions, with age only directly influencing it. A young person can be quite sick, an old person can be quite healthy. Now, could I just take 1 second to just make
Sure.
a comment about what Sharon pointed out, because I think it's a very important one. I actually trained in the States I was in the States for 7 years in Boston. And between training and working there on staff, I have a sense of the American system. And you're absolutely right. There are serious concerns. It's part of the reason I'm not down there anymore. The economics and the politics of medicine are just, they're a problem. And so the concerns that are very clearly outlined in the literature, especially amongst minority communities, and access to transplantation are real. Healthcare in general, never mind transplantation, is a huge problem there, and that will influence decisions. In Canada, of course, we're parts of public systems. It doesn't mean there isn't concerns. I grew up my family were the second people to live in Colby Village when it was a farmer's field. And I went to Sir Robert Borden and Graham Creighton. And so I grew up in that part of the province, and I had come from Ottawa, and I had never had a school that was, at that point, it was more than 50% from Preston. And so I'm slightly aware, and I can only acknowledge slightly aware, but sympathetic to the concerns that you've raised. But I need to point out that the States has lots of issues. It's different from Canada, but Canada does have some problems. And part of our dialogue is to acknowledge that we gotta work this out. Anyway, I'm happy to answer any other questions.
Any other questions or comments? So, Steve, I have one for you. Is this the first time that you've actually met with an African Nova Scotian group?
Yes, it is.
Okay.
And well, yes and no. Me personally, yes, but I've been working with Dr. Robin Urquhart. In fact, one of the things that we committed to was, as I said, trying to connect with marginalized communities. And one of the groups that Robin and I identified as a group we wanted to connect to was the African Canadian group. And Robin has been working with this community as well as others. And I've been working with Robin, so indirectly. The communication strategy was defined by the Department of Health, not by the provincial program. And the Department of Health have been connecting with members of the communities across the province. Again, it was a strategy that was defined by the Department of Health. One of the reasons that I wanted to change this was I felt like communication had to be two ways, which meant we would send out information around this new law and donation, and then people would hear about it, have questions, and say, can we talk to somebody about it? Well, I was told the message went out. I didn't get those requests that said, can we have more of a dialogue? So about 3 or 4 months ago, we basically said, let's get more active with this. I think this is a wonderful opportunity. That's why we connected with the Islamic community. That's how we connected with ISANS. That's how we've connected with the LGBTQ community and this community. We're working on trying to set up meetings with the First Nations community. We've historically not done it as well as we should. And if there's a chance to continue this, I'm all in.
Yeah, so we're not going to beat upon you, right, with that. But in fact, you know, I mean, the Health Association of African Canadians has been around for a while. And I think it's always, and you know this, I don't have to tell you, but it's always nice to get ahead of the game and to kind of be out in front rather than playing catch up. Because again, the prompt for this town hall was because we recognized and we were told quite clearly that there was a lot of misunderstanding and people weren't sure what this opt-out meant, or if they didn't even know. Some people did not even know. So I think it's great to have this, and you know, we need to kind of keep it going so that
Yep.
we can have, you know, kind of good explanation for the communities.
I think you're
Anybody else
absolutely
want-
right.
Yeah.
And we'll continue going forward.
Good, thank you. Anybody else have any comments or questions?
Jacob has his hand up.
Yeah. Hello?
Was somebody there?
Yeah, Jacob here. I do.
Okay, Jacob, yeah, go ahead.
Hey, thanks, Dr. B. Could you just, I was wondering if you could speak a little bit more and clarify, you'd mentioned it already, but I imagine, you know, with this new legislation that, you know, it's more of an opt-out instead of an opt-in. There may be situations where, you know, someone's eligible, but many or most of the family members might not be a big fan of it or have a lot of hesitations. Just wondering like how that might play out clinically in your opinion.
That's a great question because I know it's going to happen. And I think there's a starting point that we have to acknowledge, and that is that we are going to discuss what's going on with the family. And the question is, what were the last known expressed wishes of your loved one? That's a different question from what would you like for your loved one. And what I mean by that is any clinician has been in a situation where there's a tough clinical situation presenting themselves and the patient may want one thing, their family want something different. A classic example is like the do not resuscitate orders that come up, or somebody's talking about a big operation or not. We know from our data that about 10% of the time, people who have registered to be a donor, they themselves have said, I want to be a donor. And then they get a severe brain injury. We talk to the family and the family refused to provide consent. In the old law, if you will, that meant donation did not proceed. In the new law, if they have said they want to be a donor, legally, we can proceed. But I can tell you from a practical human point of view, I've been at the bedside with these families. You want to support the family. And so the decision legally is the patient's, and the law defines it. Nobody's gonna put a family through more at the bedside if there's that kind of conflict. But what it might do is it might open up a different conversation, which is, why do you think donation is something that we should not proceed with. If your loved one wanted it and you have concerns, can we talk about what that might mean? What is it that you're concerned about? Because sometimes they've got some misconceptions, and when you clarify them, they're on board. Sometimes you've got 4 or 5 members of the family who are on board, and then grandma isn't, and the whole thing changes. Those are realities. The law gives us a different way of approaching the conversation, but at the end of the day, it's about supporting the family as best we can. And I honestly, as committed as I am to this and as much as I've done it, if I have a family who just absolutely cannot wrap their head around this, personally, I don't think I can do it. I don't care if the law says I'm allowed to. That doesn't feel right. And the lawyer types tell us that, well, go ahead and do it, but they haven't been at the bedside. That doesn't feel right. So the major advantage of this law, in my mind, is that it sends a positive message around donation, and it may give us an opportunity to have a different kind of conversation at the bedside, but it's not a stick to poke people and get them to do something that they just can't do. That I don't see it that way. I just can't.
Thanks.
Great, thank you. So if there's nobody else who needs to, oh yes, I see an,
Dave,
okay, Joe,
Dave,
yeah, go ahead.
Dave, I have a
please.
question.
Yeah, go ahead.
Sorry, let me just put my hand down first. So thank you so much for the information. My question is that since the new law has been enacted, have you seen a difference in the number of donations or not?
We have seen a huge increase in the number of referrals. We're getting phone calls from healthcare team members about 5 times as often as we did in the past. So people in the periphery are learning about it and making those referrals. It has not been enough time to know whether it's going to translate in long-term change. But last year, before the law was officially in place, we had changed our program to support the new law. We had more coordinators, more education, and so on. And last year, our donor rates were very, very high. So ultimately, the system's going to be different. And I think donation numbers are definitely going to be higher, but it's a little too early to know for sure.
Thank you.
I see we have 2 other hands. Delvina, can you go first, please?
Good evening, everybody. Let me first apologize for not turning on my camera, but I think tonight my picture looks a whole lot better than me.
All right.
So I'm gonna stay with that.
Okay.
I want to thank HAAC for hosting this town hall and for hearing the concerns of even just one citizen, because often, as we know, when one person feels that, there's a whole lot of others. And actually, there were a number of people having that conversation with me over tea, over wine, over coffee, whatever. And so to the point where I thought maybe I should just fire off an email to HAAC. And I know that they have such a great track record of being responsive. So I was really happy to see this come together so quickly. And the information that I've received tonight has been extremely useful. Dr. B, you attended Robert Borden High School and Graham Junior High and Graham Creighton. Those were my 2 schools. I don't know where our years passed, but we're not going to talk about that. We're not going to let anybody know.
I'm definitely older than you.
We'll just say that they never tell the public that people from Robert Borden and Graham Creighton go on to have productive careers. And so we need to salute that. How about that? But anyway, I was just wanting to comment really about the need for the collection of more information and data on from the African Nova Scotian community about their views on being donors and about transplants, because I think we really don't have a handle on that. And I know, Dr. B, you mentioned, consultation with, various communities, the Islamic community, the Mi'kmaq community, and the LGBT community, which isn't really a spiritual community in itself, but yet we're consulted that, and unfortunately, often African Nova Scotians are lumped in with the general population. Say, for instance, in terms of the spiritual communities, the various faith-based communities, one might count us in with, because we're largely a Baptist community, but yet we all know that the African United Baptists, they actually steer very different direction than the Atlantic Baptist Convention in terms of some of their beliefs and their spiritual principles and so forth. So, I mean, I'm sure that you could probably find the Atlantic Baptist Convention saying, oh, we support that. But I'd be very curious to know if we were to poll our Black Baptist churches on their faith-based kind of interpretation of what is death, when is a person dead, brain dead, heart dead, spiritually dead, that we would probably, I'm guessing now, I'm going on a limb, we might get very different answers than the actual religion they belong to in the larger context. So I would say that the thing that I would sort of implore your office to do, and I know HAAC will do its part, is to really do more of these kinds of meetings, actually a campaign to really know what African Nova Scotians feel about this issue. Because unfortunately, and that was the fear and the conversation that I was having with friends and colleagues and family members, is that I feel that the absence of these conversations now means that people will face that question when a family member is on their unfortunate deathbed. And that's the wrong time to decide whether what you believe can tear families apart. And then also, if people just aren't connected, you may have heard a family member say, I would never be a donor, but because technically you are deemed a donor, I agree that Dr. B, that you're saying it has to feel right in terms of what the family would say, but we know people move on to different roles and so forth, and sometimes our personal convictions don't always carry through when we're gone from the various roles that we're in. And so what is policy and what is personal should never be conflated, because that might be your personal direction as a decent serving human being, but it is not what the policy says. We must always separate those two things. We can never accept that to be the way that it will, bear out in the outcome. So I would just implore those in the roles that you're in that can help to create more conversation, to find out exactly what people from this community feel about what organ donor donation involves, to have those conversations. And because, like, we look, for instance, who's on this call right now, this is such a small representation, and a lot of the people who are on here are not even Indigenous African Nova Scotians, who have very different views than people who are, from the Caribbean or from Africa, or they, so, and have a different history. So we need to get those people out and about so that they can hear and contribute to the conversation. So again, I thank you for this. And if there's any way that I can help to roust up people in our community, the people who are table talking with me, to be, I think everybody's kind of set back by the latest lockdown. Everybody's kind of in a tizzer and feel like they've been tasered in the last few days. But I did try to remember to tell people to come on. I see a few of them did come on, who were talking about this, and but I would really like to see more conversation about this, that this is the right direction to go, and for people to know all the good things that were said here about organ donation, and to even what stats exist about what percentage of people are of African descent who are on such lists, or what are we more likely, less likely to be, considered for transplants or putting our name forward for transplants or whatever the situation. We don't have any data whatsoever of how we figure out, or who are we on that list of 21 people who currently now are prepared to put their name up, or 21 out of a million, and we've got like roughly under 1 million people in Nova Scotia. Are we on that list? Have we even availed ourselves? Because if we want to be such, well, that was, but it doesn't matter so much now because we're deemed to be donors anyway. So these are all questions that I think we need to answer. There's just a lot of pieces of moving parts that we haven't answered for ourselves as a community. And with the help of the medical field, maybe you can have the resources to help us have those conversations so we can answer those questions for ourselves so they don't happen at bedside. Thanks.
Thank you,
Right,
Delvina. Dahir, you had your hand up. You took it down. Do you have a question?
No, and that's just mine still up. I'm going to take mine down.
Okay.
I
Those
think
were some great
Brenda
points.
has said.
Just to point out,
Delvina, you want to respond to that?
yeah, I guess I'm hearing my own echo, which has confused me, but
Okay.
thank you very much for those comments. I think they're spot on. This is the start, not the finish. So if you want to continue a dialogue, I think that's awesome. I'm certainly happy to support continuing that. Some of the information you're asking about the data, we have that. In fact, some of it's on my slides that I couldn't get up here, but I can tell you, for example, that in the last 3 years, there has been one African Canadian donor in the last 3 years. Nova Scotia's census shows somewhere around 2.5% of the population identify as Black, ballpark. So that represents slightly lower than the population base, but you'd have to really drill down on other things, who's dying of strokes and subarachnoid hemorrhages and so on. So a medical conversation like that would be appropriate, but overall, I think it's reasonable to say that that community is underrepresented in the donor population, but maybe not by much. But hypertension, diabetes, things like that lead to kidney failure, for example, are certainly common problems. So a conversation around that and how this is relevant to this community is a great thing to do. The comment here about the 95% of the population, there was a survey commissioned in February of 2020, and it was one of these professional survey outfits that come back and say it's within plus or minus 3%. We sampled 1,001 people. So they will tell us that they had a sample that was representative of the population in terms of urban and rural and race and age and so on. But the exact numbers, I don't know. But this survey company would tell you that they had a representative sample. But if they did have a representative sample, then that may have only been 25 people. And it's awfully hard to know what a large community thinks when you're only speaking to a small number of them, as you guys all know. Take home message, I loved your comments and happy to continue a conversation in the future.
Okay, time is going on us. Dahir, if you have a quick question.
Well, most of the questions I had were summarized better than me by Delvina. I just wanted to make a case. I happen to be Black and also Muslim. And this conversation was actually in the prayer song on a Friday in late December. So it's a little bit upsetting that some people of the local community have not even heard of it, even to this point. So that is something that definitely needs addressing.
Yeah, okay, good. Hear you loud and clear. Sharon, I'm going to pass over to you because I think we need to move on now. And
Yes,
if anybody has any additional questions, sorry, Sharon, you can just send them to us by email, info@haac.ca, and we'll respond. Thank you.
And indeed, this is being recorded and it's live on YouTube, so it can be accessed by people later who weren't able to be here tonight so that they can hear the comments, they can hear the presentations, and I would urge everyone to pass that on. So they haven't missed it. They have the opportunity to hear it again. At this point, I would like to call on our colleague, a dedicated board member of HAAC, our own Dr. Jacob Cookie, who is also a psychiatrist, one of few psychiatrists of African ancestry serving in Nova Scotia. And we wanted Dr. Cookie to talk about the psychological impact of both being asked, both having to ask, and how we cope with that, because it's a very sensitive time. Obviously, you know, very few of us actually have been in that situation. So Dr. Jacob, help us to understand a little bit more about this, if you would. Thank you.
Thanks, Sharon. I'll keep it brief, and I'll just put up front, I'm not an expert in organ donation and not clinically involved in it, but have been exposed to some of these conversations just in my training through medical school and residency, and so more just approaching this from a general perspective in terms of general mental health, but open to discussion for sure and questions. So I tried to just briefly have one or two points there's many different perspectives, like you said, Sharon. So from the provider perspective, so, you know, us in healthcare, you know, pitching this idea, as it were, to family members, that can be, you know, stressful at the best of times, you know, intimidating and scary at the worst, especially when you know there might be quite a negative or strong response to these conversations. So just to keep in mind that the healthcare providers themselves are human beings too. I'm sure Dr. Peeds had his share of stress going through some of these conversations. As a healthcare provider myself, and especially if, you know, you're coming from a Black community, that could be even more challenging because it's not the biggest community in the world here. And so you're almost certainly going to have either know or have some connection with the person, especially if you are from African heritage. That can make it even more difficult. You're then approaching you know, either a distant relative or someone in your community, or that you likely might see in the not too distant future. So I think just to keep that in mind, that it's, you know, the healthcare provider themselves will need to be mindful of their own stress levels, their own mental health. And one of the guideline or the principles that have come across when I was reading about a bit of this is, and it you know, many of you have already mentioned it, but the idea is that you're at the end of the day coming to a decision that's in line with both the patient and the family. There can be tension there. That's why I asked the question, because I just wanted to get a sense of how that might play out. But ideally, when you get to that point, you then make a decision where later the decision's not regretted either by the family members, you know, afterwards. And some of the things that go into that, at least from what I remember during my few times that I was in this situation, it really helped to have a number of people in the room during this conversation, both from the family side and the healthcare side, so that you have all the expertise and support there you need to deal with whatever comes up in the room. That could be anything from the physician themselves, the bedside nurse who knows the patient very well, the relevant family members, but also like a cultural representative could be extremely useful, especially if there is someone from the community, or a spiritual care representative, a priest, a pastor from the community could go a long way to kind of quell a lot of the tension in the room. Ideally, other things would be in place too, but I think those are some of the key elements from the healthcare provider perspective. And also really wanting to minimize the pressure. You don't want to, you know, come across at all as coercive or you know, kind of pushing people in terms of being tight on time, if at all possible. So that's from the healthcare provider perspective. Switching to more of the family, the organ donor perspective. Again, a lot of this has been said, but you know, there's a real and historical mistrust with the medical system in the Black community, again, for good historical reasons. And it's not easy to overcome that when it's been your parent or your grandparent who's gone through this or experienced this. Other things that come up a lot, in addition to what Dr. Beat has already said, are things even like, what will happen to the body if we want to open casket at the funeral? Will it delay funeral proceedings? Is there a cost to this? Will it desecrate the body? So there's a lot of beliefs, misunderstandings, myths, and that can only be really sussed out with a good, conversation, where you're taking your time, where you're listening. There's a back and forth, especially with, minority communities, because as many people have mentioned, very, very much reduced rates of donation amongst minorities, at least, when I was looking up, it's mostly American data. Dr. B could speak to more local data, I'm sure, if we have questions about that. But a lot of that does stem from that historical mistrust, and maybe even just, the idea of how much solidarity you have with broader society as someone living as a minority. So from a family member standpoint, in terms of steps to take or ways to approach it, I think, like we're doing here, just this alone can be so beneficial, talking about it out loud together as a community. And interestingly, Divina brought it up. I happened, as part of my research, to come across, at least it was a US study, so it's not local to Nova Scotian, but in the US, similarly, the Baptist Church is largely the primary religion that people identify with. And they actually looked at African-American clergy members and did a qualitative study about their perceptions, beliefs, and so on. Again, they actually did overwhelmingly support organ donation, except interestingly, they mostly felt that many of the parishioners didn't. Like there was a disconnect between the clergy and the parishioners in terms of, again, this is polling the clergymen about what they thought the parishioners might believe. So supposedly they're getting this information from their conversations with their parishioners. But the authors of the study identify, one of the big needs would be an ideal kind of venues to do some of this work within the church context. Within it can be very powerful to hear some of these messages through spiritual leaders in the community. So that's just one thing that I found interesting that came up. And then so finally, the last is the actual person, and we don't talk, I guess, too much about this, but the person receiving the organ. That person themselves have a lot of considerations physically, because they've been living with this condition for quite some time, often before the organ's ready. They might have comorbid psychiatric conditions, depression, anxiety, substance abuse issues. So I think it's very important to keep that in mind, to provide that person the care they need physically and mentally, optimizing their physical and mental health prior to, during, and after the procedure. And I think one of the big things that can actually be positive both for the donating person, the donating family, and the person receiving is having a good outcome. A lot of, I think, families, from what I'm understanding, when they do get to a point where they're okay with the organ donation, would want to see the person who gets their loved one's organs to flourish and do well. And so those stories can be really powerful. I know there's issues there with confidentiality about connecting donating families and the person who receives it. But even without that, I think hearing about it and learning about these types of stories are an important part of the process. So that's and then the one other thing that I found just interesting in relation to the Black community. Again, this is American data, but it sounds like there might be hints of it here in the Nova Scotian Black community. Is that the donor list in the community is much lower, but the size of the list that requires organ donation is much overrepresented. So in the states where 13-15% of the population is Black, apparently the list is upwards of 30+%. So there's a disconnect between us who need it because of almost certainly things like hypertension, higher risk of cardiovascular disease, diabetes, but a lower amount of us able or willing to give, again, because of a lot of real historical reasons, cultural reasons, and so on. But so I'll stop there, but those are just some of the things I thought it might be good to consider and talk about.
Thank you so much, Dr. Jacob. You are always there to help us with those kinds of reflections. We have very little time before we want to invite Dr. Nevis and Dr. Mucci to talk about their work, but I want to give people, at least a minute. If anyone has a question or a comment with respect to the psychological impact that Dr. Jacob has just spoken about. And Dr. David, help me find if there's someone or if there's a question out there or a comment. I don't see one.
Could I just briefly say one of the parts of the new legislation, deemed consent gets the headline, but we built in enhanced family support, and that does include a mechanism to connect the donor family to the recipient family. That's part of the new law.
Okay. Thank you for that. And Delvina, is that a question that you have, or is your hand raised from former?
No, it is a question related
Okay.
to Dr. Cookie's presentation. Thanks. It was when it was noted that confidentiality issues with respect to the recipient versus and the donor. And I was just wanting to know what is the protocol on that. And I'm going to bring a very unpleasant reality of racialized trauma that I know, and sometimes I'm always accused of speaking the real, that there are Black people who would say, I would just roll over my grave if I knew that my organ went to a white person who was a known racist. And the family would be left with the trauma of that to say, if she had only known. These are the unfortunate realities of living in a racialized and racist society. We would hope that that should never, ever be a consideration. But unfortunately, the racial trauma that people experience, that they would actually be really devastated and psychologically traumatized by a donation to someone that they know was wittingly had behaved in their life to be what's the word I'm looking for? Who's someone who's just unkind, I guess, to people of color. And that's just the reality, So how much information are people privy to?
Very good question. I appreciate that. Thank you. Dr. Jacob, do you want to take a shot at that?
I would defer to Dr. B because I'm not familiar. He did mention there's a mechanism to overcome the confidentiality problem, but I'm not familiar with it personally.
Historically, donors and recipients didn't connect, and all the donor family was told would be something like, your dad's kidney has gone to a 47-year-old man with 3 children and he's doing fine. That was it. In the new law, there's a process. It has to be at least a year since the donation and transplantation. There has to be consultation between both the donor and the recipient families that's handled by our program as the intermediary, because the potential for things to be wonderful exists, and that's what everyone hopes for, but the potential for it to go terrible also exists, as Davina pointed out. So we would anticipate that when that evolves, because we haven't started it yet, it's going to be a year from now, that we're going to have to address those very concerns. Everybody wants this to be like a wonderful moment, but boy, oh boy, it could go sideways.
Can I just jump back in to say, I'm sorry if my comments sounded harsh. I couldn't find another way to say it, but I think you guys got the essence of what I was saying. It's really the trauma of the family afterwards who would say that, because obviously the donor is unconscious, so they don't know that.
Yeah.
But I mean, the family later on finding out what kind of family, what kind of donor, what kind of recipient was this, they would walk around carrying a sufficient amount of guilt. End up on Jacob's caseload, Dr. Jacob's caseload.
Well, I personally want to thank you for speaking that so clearly, because that is a huge concern. That would be a concern. That would be a concern for me. So I appreciate that. And I think this is what these opportunities provide, is that kind of open dialogue. So it will inform Dr. Bede and inform the rest of us going forward. And we always will welcome your voice to speak truth to us, Delvina. Thank you. Moving on now, because of time, I certainly want to give the opportunity to Dr. Nevis and Dr. Mucci to talk to us about their work in other parts of Canada. Obviously, TO is one part, but it may not be all of it. So I'm going to say over to you to introduce yourselves and to connect perhaps what you want to share with us with what you've heard, which is very powerful so far this evening. So thanks in advance to you both.
Thank you very much, Sharon. I will be starting us off. Thank you very much for including us as part of this very, very important conversation. My name is Paula Neves. I'm the lead for the Center for Living Organ Donation at the University Health Network. And it's a very small group within UHN. It was started in 2018 by a living kidney recipient and her husband, who is also a living kidney donor. They were motivated to improve access to living kidney transplantation, and made a donation to the foundation, and that enabled our center to be established. Our mission is to improve access to living kidney and living liver donation and transplantation. And so we have been working on a number of projects, and I'm hoping that you're able to see my screen. Let me just see if I can share it. Can everybody see that? So I'll start off, but I will be joined tonight by Sharon Mucci, who is a nephrologist and a researcher at UHN, and by Lydia Joy Marshall, who is a researcher and also a community engagement specialist with this project. And I know that there are a number of other team members who have joined today. So we will be talking a little bit about a project which started a little over 2 years ago, close to 2 years ago, called Action. And it has a very descriptive name and a very creative acronym, which we hope will actually mean that we are going to take action to improve rates of living kidney and donation. So it's focused specifically on South Asian communities in BC and African, Caribbean, and Black communities in Ontario. This project, when it was initially conceptualized, was really province specific. We have co-leads from a research perspective. We have Dr. Jagil in BC and Dr. Mucci in Ontario, and originally focusing on those communities in those provinces. But as the project is evolving, we are looking to expand those geographic areas so that we can include the South Asian communities in Ontario and African, Caribbean, and Black communities in other provinces, including potentially in Nova Scotia. We think, it's really, this is an opportunity for us to look at this, at needs, at gaps, at opportunities for us to make significant and long-lasting change, and that change will take a while. But this is an opportunity for us to have a good discussion and potentially to collaborate in some of these areas. So the project, when it was conceptualized, it was really looking at trying to understand disease burden in these communities, in trends in organ donation and transplantation. And that very basic activity has proven to be a bit of a challenge because it's very difficult to tease out race, ethnicity, et cetera, in the existing data, and the extent to which we can rely on the data that's been currently available without having patients actively self-identify is a challenge. In addition, we were also looking at having a fulsome assessment of barriers, gaps, and needs of patients, of clinicians, of community members in terms of organ donation and transplantation. We foresaw that there was going to be a need to look at cultural competency and anti-racism education for clinicians involved in kidney transplantation and kidney care overall. And we also, as part of this project, wanted to do a pilot intervention and evaluate it. So taking all of the information from the data that's currently available, data that's been published, data that this project would collect, and try to pull it all together in collaboration with our community partners to develop a pilot intervention and evaluate it to see if there was a way that we could improve care and improve outcomes and make long-lasting system improvements. So as you can imagine, COVID has thrown a few barriers our way, in addition to some of the others that we were likely to face. We'll be talking a little bit about some of those in a minute. But part of our activities and a lot of the work that Lydia Joy in particular has been doing is patient, community, and clinician engagement, and how important that is at all stages of the project. Not only at the beginning in terms of planning the activities, but also as we move forward and develop the pilot, determining how that pilot will be carried out and how it will be evaluated will also be important. This is one of the earliest sort of outcomes so far of this project. This is a scoping review that was published in March, and it was led by Noor El-Dasuki, who was the coordinator of the project, and she was able to work with a broader team, and you'll see those listed here. And really, this is meant to summarize some of the barriers from the academic literature in terms of barriers faced by populations marginalized by race and ethnicity in Canada. It's focused specifically on kidney transplantation in the Asian and African, Caribbean, and Black communities. So today we thought we would tell you a little bit about some of the work that's been done to date, focusing on what we know about kidney disease, kidney failure, and kidney transplant broadly, and then with respect to patients from the African, Caribbean, and Black communities, some of our findings, both from a quantitative and qualitative perspective, and then where we're at now and what's next. So I will turn it over to Dr. Istvan Mucci, who's going to review the next few slides, and will also introduce himself and his role in the project. And I'll advance the slides for both team members. So Istvan, over to you.
Thank you, Paula. Good evening, everybody, and thank you again for having us today in this conversation. I'm glad that we can be part of this, and I think it is an important thing to. Probably this is the most important step of the conversation, and this is where I think it has to start. And this is the vehicle or the medium that hopefully help us moving things forward. I will be talking about some of the results that we have and a bit of a context and broadening the context from deceased organ donation to chronic kidney disease in general and living organ donation, as Paula already mentioned. But before going there, I think it is important in this context to emphasize that I am coming from outside. I'm a white physician, a middle-class person, of many sometimes unrecognized privileges that will influence my thinking and my feelings. Also, my position as an academic nephrologist, a specialist in this area, obviously will give me a lot of knowledge from on the one hand, but certainly may bias my opinions in other ways. And it is important to acknowledge this in this process and as part of this conversation. And as this has come up already, another source of bias and uncertainty here is that the data collection in our process is still at kind of a relatively early phase, and we will have a better understanding about what we found actually as we move forward and complete our analysis. So opinions within the team also may be somewhat different, and I think I will try to go through the slides. Next slide, please. Somewhat quickly, because some of this has been mentioned already, and I also want to leave enough time for Lydia Joy to discuss the findings of the qualitative work that we have started a few years ago. I think it is important to broadening the scope from the organ donation, which is really the end of a process, to when we talk about kidney transplantation, to kidney disease and chronic kidney disease, because this is how it starts. This graphic describes the course of a patient's kidney function and the journey that can last from 5 to 10 to 15 years, from a normal kidney function down to the end-stage kidney disease, where the kidney function is only 10% of normal, and this is where transplant or dialysis is usually needed. And it is important to have this discussion and at least thinking about this in this context, because kidney disease in general doesn't have symptoms early on, and many people will not know that they have kidney disease until it's late. The next slide, please. And it is important to recognize kidney disease early, because with appropriate treatment early on, this course can be modified and many, many years can be gained without needing dialysis if the treatment is started early and if the treatment is done appropriately. And also, as it has been mentioned several times, diabetes, hypertension is important risk factors in this. And the management of those also needs an ongoing discussion and conversation between the healthcare system and the patient and their families. And the trust issues and the mistrust, the experiences with healthcare system will also put some barriers to this treatment. So many patients may end up on dialysis or needing dialysis because their treatment was not good enough, the discussion and the conversation was not wholesome enough early on. Next slide, please. And this is the definition of kidney disease, and end-stage kidney disease is when transplant and dialysis is needed, and it is around 10–15% of normal kidney function. Please, next slide. And again, many of you know, but I really cannot really emphasize enough the importance of the risk factors and the recognition of the risk factors, both because addressing some of these risk factors can prevent kidney disease, but also these are important factors after kidney transplantation. Diabetes, high blood pressure, obesity, smoking can also influence the outcome after kidney transplantation. So it is important to recognize these and address these early on. Next slide, please. So again, just to put in perspective, Dr. Bede mentioned the difference between living with a transplant and living on dialysis. Dialysis is life-saving. For many patients, this offers the chance to live a wholesome life, but both hemodialysis and peritoneal dialysis, and it's actually, I just recognize that it's the terminology is swapped on the slide, so that gentleman with the glasses is doing hemodialysis and not peritoneal dialysis. But both of these are quite burdensome and require a lot of time and work. And kidney transplant is a surgery. You need to take medications after, but then the quality and quantity of life is usually in general much better than on dialysis. Next slide, please. There are two types of transplantation, organ transplantation, deceased and living donor transplant. And it is important to emphasize this because of the waiting time, because of the burden of dialysis that patients can face, and waiting for the appropriate time is different between these two. With living donor transplants, you can get an organ transplantation relatively quickly. Those organs will work better, and usually they work longer. Deceased donor transplant always carries risks of unknown and uncertainties, both medical and otherwise. And certainly waiting time can be quite substantial in Ontario and in BC. Again, I'm not quite familiar with the Nova Scotia data, but here in Ontario, the waiting time can be anywhere between 2 to 10 years on dialysis. Next slide, please. Quickly, what the chronic kidney disease or end-stage kidney disease means. On average, if you start dialysis, your chance to live in 5 years is around 40–50%. If you have a deceased donor transplant, this goes up to 75% or so, and the living donor transplant will further increase this survival chance compared to staying on dialysis. Again, just put it in perspective. If you have breast cancer, the 5-year survival chance is about 80%. With colon cancer, it's about 60%. So being on dialysis is very similar to having a cancer diagnosis. Next slide, please. Just put it in graphically. This is based on American data, US data. If you are 30 years old and your kidneys are failing, if you're going to stay on dialysis, that is represented by the black bar, your chance of living for or survival is about 15 years. If you get a deceased donor transplant, this survival expectation goes up to 30 years or so. With a living donor transplant, it increases further up to 40 years or so for a young person who is at this decision point. So this is what a transplant can mean, and this is what a living donor transplant can mean compared to being on dialysis. Again, these are average overall data and based on US data, but the data is probably not quite dissimilar in Canada. Next slide, please. Why is this important? This was again touched upon partly earlier on. This is a graph of the proportion of patients based on their home country who are on dialysis. And as Paula and others mentioned, we don't really have good data about ethnicity or self-identified race in Canada. This paper was trying to address this question based on country of origin. And what this graph shows is that these people who immigrated to Canada over the last 30 years compared to people who were born in Canada, what is their proportion of being on dialysis? And as you see in the lower parts of the slides, you see a number of Caribbean countries. And in the mid and top part, you see several African countries. And this indicates that people who immigrated from those countries have a much higher chance to be on dialysis compared to people who are born in Canada. Next slide, please. This is putting into regions or collapsing this into regions. So people who come from Latin America or sub-Saharan Africa have at least 2 or 2.5 times more risk of needing dialysis compared to white individuals in Ontario. So as it was mentioned, there's a much more need for dialysis, much more burden of chronic kidney disease and end-stage kidney disease in the ACB community. Next slide, please. And in comparison to that, if we look at kidney transplant and living donor transplant, what we see is that compared to white patients on the top, patients from the ACB communities have about 50 to 70% less chance to get a living donor transplant in Ontario now. This this data is from our center, but the data is similar in the province, and also a number of previous studies in Canada demonstrated similar inequities. So patients who come from racialized communities, specifically from African, Caribbean, or Black communities, have at least 50% less chance to get living donor transplant and transplantation in general as well. Next slide, please. And we wanted to explore the reasons. And also, as Paula mentioned in the action study, we wanted to make steps towards addressing these issues. And we will show you a few pieces of data. Next slide, please. Our quantitative study is based on questionnaires that we asked patients who have kidney disease before transplantation about certain things related to transplant. When we asked patients who belong to different communities here, the ethnic or racial background is self-identified, whether they had a living donor already at the time of their transplant assessment or not, we found that people who belong to ACBs, Asian communities, they have twice as likely to say that they did not have a living donor. When we asked these patients whether they would want to accept or that they were willing to accept an offer, if someone offered them a living donor transplant, everybody said that yes, they would want to have that. But for some reason, patients who came from these communities, they were not able to secure a living donor. And of course, as I put it on the previous slide, if you want a living donor transplant, the onus is on the patient to identify a donor or the family, whereas a deceased donor is being identified by the healthcare system. Next slide, please. Frequently, transplant-related knowledge in general is being mentioned when one wonders about the reasons why patients may not explore different types of treatments. And surely when we asked patients about the transplant-related knowledge, this slide describes the blue bar indicates the high transplant knowledge, the red is the medium, and the green bar is the lower end of a transplant knowledge scale or score. More white patients had higher scores compared to patients from ACB, East Asian or South Asian communities. At the same time, when we asked about basic characteristic, when we asked patients whether they knew that transplant was better in terms of survival or quality of life, patients knew that difference. So the fundamentals were known in both communities or in all communities. Next slide, please. And an important difference what we found was that patients from racialized communities were much less likely or much less willing to communicate about their condition and ask others to help. And this was true in many aspects. This figure describes the proportion of patients who said that they did talk to others, their family or friends about transplantation. And compared to white patients, patients from the ACB, East Asian communities, and even South Asians were much less likely to have discussed these issues with family or friends. Next slide, please. There were additional concerns around the pain and surgery, the concern about medications, and also in some cases, concerns about expenses. Next slide, please. But this is only a very small part of it. And as it has been discussed before, we really need to talk to the individual people to know more and understand the reasons. And this is what we're trying to do in the qualitative research. And Lydia Joy will talk about the findings, with the initial findings. Thank you.
Thank you. Good evening, everybody. So I know it's been a long conversation, but so as Dr. Mishi said, you know, the part of the conversation that I think is really relevant to what we're talking about tonight is really having conversations with people in community and ensuring that those voices inform some of the questions that came up from groups before, some of the things that inform policy, the things that inform decisions and why things are happening going forward. So our part of the study to look at to see, you know, what do people in our various communities feel? So we made a very concerted effort to speak to people from all of our diverse communities. You know, as we know, I know those of you in the different coasts seem to think that in Toronto, we always are Toronto-centric, but we did consider all of our diverse populations. And we actually started with generational Black Canadians. That was the first group we started with to ensure to anchor it with that voice. So which is interesting, a lot of the comments that I've heard tonight did really overlap with some of the information that we heard also. You know, it's difficult, as we know, sometimes to speak in our communities, who wants to speak, what has happened, but we try to ensure to give a voice to people who are at all ends of the spectrum. So whether they are patients, caregivers, whether they were general community members who had not yet been part of this at all, just to understand what their understanding was with the nephrology pathway, with the donation pathway, and just our general ideas and about healthcare being Black in the healthcare system. So this was something that we really made an effort to try and address as much as we can. It's still a work in progress. As Dr. Neve said, you know, COVID definitely put a curveball in who we were able to speak with, but we did get some very good initial findings. Next slide. So, you know, I think the same as what you're saying, we really did start looking at, you know, speaking to people and saying, can we just hear how and how you feel about everything that we've done? So we've set up people, we had groups in community, so where people already met. So whether that meant, you know, at someone's home, in a church, in a regular place of meeting, we went, we shared a meal, and we sat down and had a conversation. And we said, you know, let's first talk about what is it like being Black in the healthcare system, just so that we'd really understand what that meant. And then we went from there to talk about how does that inform your decisions around organ and tissue donation. So, you know, a lot of the things that we heard are what we heard today. You know, we don't need to speak to ourselves about it, but I will kind of review with you some of the major themes that overlapped and otherwise. Next, please. So I think we've heard this word a few times even tonight, this idea of trust. But, you know, just to expand on it, it's what is there a lack of trust in? There's a lack of trust for, as we've heard multiple times tonight, valid reasons of medical racism that we know exists here in Canada. We've unfortunately had to refer a few times to American sources because that in itself is a form of racism of why our stories have not been captured and are not recorded, that we can say this is what we feel here. So there's good reason of, you know, where's our data going? Who's collecting this data? Who's asking the questions? How is it being interpreted? People spoke to us about not only their own experiences that were that they felt that they weren't respected within healthcare, but communal experiences of why the system is not trusted. And so that was the number one thing of why people spoke about whether they would be a donor, whether they would be a recipient, how they felt that the whole system worked, and whether or not it was actually for them or not. The other theme that we heard over and over and over again was that there needs to be greater representation from our communities on every part of the journey. So whether that's in those making the decisions, as we've heard tonight, those setting the policies, whether that's in healthcare providers, whether that's in those supporting us after we've gone through the journey, it makes a difference of who's sitting there, so that it's not an afterthought to say, oh, by the way, you know, what did people in these communities think of? That from the beginning, everybody's perspective was thought of. And so this was something that we heard over and over at every spectrum of, you know, we want to see people who look like us. We want to hear stories that are from our communities so that we know that our concerns have been incorporated every step of the way. Another thing that we heard a lot was the idea that, you know, what are our cultural norms? What do we see as healthy? What is appropriate holistic care? What do we think needs to be incorporated in order to ensure, hopefully we don't get on the donor list to begin with, all the factors that Dr. Mushi was speaking about. What are the things that are within our control and within our cultural norms that we feel healthy and able to control our own outcomes within that? I think another part that was very interesting was we spoke to a lot of HCPs, healthcare professionals that were from our community. And we know there aren't very many, but the idea that they themselves were feeling marginalized and burnt out in trying to have this conversation and advocate on behalf of us. And what does that look like when, you know, when you're standing and you're one of few trying to advocate for a whole community? And the last thing that we heard over and over again was the need to just have this conversation, like conversations like we're having today about what does this journey look like? What does donation entail? Who is eligible? Who benefits? Are everybody's concerns actually being considered, whether it's psychological or physical? And, you know, we know for ourselves that many of our communities were proud people that either internally or externally we're not having these conversations. And it's something that needs to be changed. It doesn't necessarily mean that it needs to be changed from the institution. It might be something we need to be responsible for ourselves, but it's something that people spoke about of not having some of the information or having the conversations that we need to have in order to protect our health. Next slide. So I always like to, I don't like to speak on behalf of people. And, you know, if we get to speak again, or we get to meet again, there's many quotations that I could have brought up today that kind of exemplify what some of the people in Ontario have felt about both the system on a whole and about organ donation. And from some of the comments of what I've heard today, I think it resonates and unfortunately does overlap with what's happening in Scotia also. You know, one of the quotes that stood out for us was, you know, we don't understand and we don't believe that the health system is for our best interests. So there's a degree of suspicion, and the suspicion could result in us not revealing information that could be valuable, and also at times giving misinformation because we're not understanding what's happening. And I think, you know, it plays a big role even in the conversation we're having today when we're talking about having informed, like opting in or opting out of the system. What information are we going to be giving when we're saying, you know, at what point in the journey are we asking our permission? Are we having these conversations? If we don't feel a part of a system, it's terrifying to say, you know, that choice might be taken away or it's been made outside of yourself. So knowing that this is what a group of people have felt like for justified reasons, how do we change that narrative? How do we change those conversations so that those voices are included and we don't have to feel that fear, and that we actually feel like this system is something that we built together? Some of our community members said specifically, you know, that they don't even like the idea of filling out a registration card, which we are not yet in the system that you're in. So it's still that you have to opt in, and because they feel like they'll give up on trying on you because the 4 other people who are lined up who need organs. And I think, you know, we did address this earlier as one of the concerns or one of the prevalent ideas we hear, but I think it's not the same as generalized Canadian fears. A few people mentioned it. I think it's really a sense of, you know, are Black bodies valued or viewed as valuable? And some of the historical things that have happened make us feel not only that, you know, will they not save your life, but what is the system that happens after that? Will it be equity in how things are distributed and how you're treated and how you're respected? Next slide. So, you know, we know that this is not an easy answer, and you know, this conversation today and across the country are some of the things that are important in changing this. But we know there's multiple parts of this that has to happen. So we know there has to be system change, looking at systemic racism. This is not an individual problem. This is not only, you know, Black people don't trust the system or an individual healthcare professional is not good. There are systems that are in place that have divided us and have not ensured that we're all ensuring equity and equal treatment within the healthcare system. So we need to be working on that, while at the same time looking at better cultural inclusion of all of our diverse communities, ensuring that our stories and our narratives and our beliefs are just as equally valued in decision-making and how we treat one another. And then we need to take this information and that there be a transfer of knowledge in both directions to ensure that the institution and healthcare providers understand what our communities think, feel, what our fears are, what our strengths are, and that there's a transfer of knowledge of this information when we're speaking about how do you become, you know, optimal donor, recipient, or hopefully not have to be on that spectrum at all, but just this having a conversation about our health and empowering us to understand what that looks like. And then building support systems to keep that going and make sure that, you know, there are people from our community who are able to continue that. And with all of this, hold each part of the system accountable, hold ourselves accountable for our own health, hold the system accountable for things that can be changed, and make sure that all of us are working together to continue that we don't see that we disproportionately need to have organ donations, but at the same time, we're not participating in the system. Next, please. So that's what we're looking at. How do we bring this all together? So how do we bring together so that the conversation is led by community, that we're able to support each other in peer groups, that we're able to know that the systems that are, when we go to the hospital and we're part of the kidney program, you know, that these have been informed by all of our different communities. And the transplant program, you know, it's something that's transparent and dynamic, and we're working together. And in doing all of this, there's a focus and a center on the patient, the family, the community, and those who are being served. And so that we really know that those voices and what's needed, that's the main focus. Next, please. I feel like I'm voguing to change each one. So, you know, as Dr. Mishi said, we have not completed this work. There's definitely been some delays, as all of us have been, because of COVID and other things that have happened this year. But, you know, some of the things that we are working on to use what we've heard of what people need is there's some 3 main pillars that we're looking at. The first is making sure that there's cultural competency and safety and education within the pathway. So some of the things that we spoke about today, so that when decisions are being made, there's an understanding of why there's a fear. It doesn't have to later be like, oh, by the way, we're seeing people are not participating or having conversations. That information, is an ongoing conversation, so that we're understanding what the history in Canada has been. We're understanding what the healthcare system has done, what it hasn't done, and what we want it to look like. And in doing so, we want to co-develop with those who are greatest impacted, those who are marginalized the most, develop programs to educate ourselves about kidney health and transplant pathways, so that we know both what we can do within our cultural norms and otherwise to ensure that we really are able to empower ourselves within that. And then the other thing that I think is important is just community, like just sitting on this call itself, it really just warms my heart that we're sitting. It's unfortunate we have to be on Zoom because of the pandemic, but still just the idea that we need to connect, we need to talk to each other, and we need to support each other, and we have to have these conversations. And, in order to create culturally safe places that these conversations can continue happening, that are led by community, is one of the things that we want to support. Several of our members, several of our partners are community members and community groups that we're looking to see how can we ensure that this isn't just a one-time project. This is something that going forward, the conversation continues. I vote. So I think just our last slide just shows some of the partners that we do work with that are in Ontario, because the African, Caribbean, and Black communities that we work with are from Ontario. But we hope that we'll have some partners that are across the nation and otherwise that are informing what our diverse Black communities do think and how we can work on these same problems or solutions that are joint and the voices that we're hearing. So thank you.
And these are just pictures of some of the team members who've been part of this work. And as I said earlier, I think some of them may have joined today as well. I think Rhonda may be on and others.
Okay, thank you so much. What a fabulous presentation that was. And I think are you going to invite maybe some of us to be involved with your work, Dr. Jeeves?
Absolutely. We'd, this is really the start of a conversation. We would like to invite as many members as would be interested in being part of this work. Certainly, we recognize that your situation is different, and having focus groups and interviews with community members and community leaders would be important. You've got a different system as well. So, and a different history, a unique history, and it's important for us to recognize all of that. And there's also some initiatives that are currently in the planning stages that would benefit from your involvement as well, including a new ACB kidney or organ health YouTube channel that is in the planning phases, and a pilot project that I mentioned earlier that could benefit as well from some additional input.
Okay, so would you then say that people should write to us at HAAC to express their interest in perhaps being connected to some of your research and work? Can I get that from you?
Absolutely. I think whatever is the best way for folks to be involved. Obviously, we will work with your organization, Sharon. So there's probably, as I said, this is the beginning of a conversation. Yes. So we welcome your input on how we do this, and would welcome your members and members of the community and their involvement in this work. So if folks who are interested could sort of connect with you, I guess, and members of your team, and then we can have a follow-up conversation about how best to move forward.
Okay, that's great. Dr. David, over to you to wrap this up and invite our people to be part of the big picture.
Okay, Paul. Yeah. So we're sort of at the end of our time. I don't know if anybody has any final questions or comments. We've had a really great presentation. And
I really think this is.
Yeah, go ahead, Joe.
wonderful presentation. I think it hones it in and it brings it together. And I think it's a wonderful way, a good segment into conversation and dialogue. So thank you for this. It's been amazing. Thank you so much.
Okay, thank you. There is a nice comment in the chat. You can all have a look at that. So we're going to wrap it up. We've kind of gone on a journey here together this evening. Sharon, you framed it up very nicely. And to recognize and acknowledge, and again, Lydia Jo, how do I pronounce that? I'm not saying that right.
I want to say Joy. Is that right, Lydia?
Joy?
Joy. It should be Joy, but my Caribbean parents don't pronounce it properly.
All right, Lydia Joy. Okay, great. So you in your presentation too, you encapsulated a lot of the things that we've been talking about, you know, the fact of mistrust and just that whole issue of, you know, not understanding what this is all about. I mean, it's very clear from what Dr. Bede said that organ donation is a very key treatment for people with end-stage organ failure. And, you know, again, for us in our community, there are lots of us who need organs to treat, you know, some of the underlying chronic diseases that we have. But again, you know, there are not that many of us who are willing to step forward and donate organs. So I think it's very important that we've started that dialogue tonight. I mean, I think it's a start. And it was very good of Dr. Bede to explain the legislation, because when it came out, there was a lot of, you know, concern, and hearing from him exactly what it means and what the opt-out issue is and the bedside conversations that can take place. I think that was excellent, and, you know, will help us as we move forward as a community to kind of come to grips with this whole issue of organ donation. Certainly not done. And then Dr. Jacob, was great to have your perspective on the mental health issues that the provider can have, the donor, the recipient. And I mean, again, it's all intertwined. So we need to be paying attention really to all the bits and pieces of it. And again, we thank you for joining us from Ontario to give us a snapshot of what you're doing, all the good work you're doing with the living organ donations. And again, you know, a lot of the things you talked about are things that resonate with us as well. And I think it, you know, we look forward to all working together. And Dr. Bede, we're going to continue the dialogue with you as well, going forward. So we're going to call it a night, Sharon. I don't know if there's anything else.
I just want to reiterate, I want to reiterate that this is being recorded and will be available, in our amazing admin person will make people aware that they can find this recording, that where they can find it, and that they can pass it on to others who were not able to be with us tonight. And also, if you're interested in being part of this research, you want more work done, and you want to be connected to it, write to HAAC at info@haac.ca. Correct, Dr. David? I've got that right?
You got it.
Okay,
Yeah,
so
Sharon, there was a hand up. There was a hand up, and then he put it down. I wondered what he was.
Okay, let's not do that.
Who was that?
It was me, and I was just wanted to reflect very quickly on something that Dalvina said during one of her comments, and I think it is critical to this area, but probably for many things. I also mentioned knowledge, and Lydia Joy used to comment on what is knowledge and how knowledge is acknowledged. And we always think, especially in medicine, that knowledge is very important, but we need to recognize that our behavior is mainly driven by our emotions and feelings. And our feelings and emotions can only be tailored or softened by conversation. So I think talking to the people, as Lydia Joy said, understanding what the other is saying is the only way to start understanding how a community behaves, and also trying to make this world, make the system a bit bit better for all of us. And I think some of the work that we are trying to achieve is aiming for that. And knowledge is important, but also our feelings are very important. And probably Jacob also kind of agrees with that. And it is important to consider in any medical decisions and conditions and processes. Thank you.
Great. Thank you for
Dr.
that. Yeah.
Mucci, and thank you all. And indeed, we want to say goodnight to you. Do have a look at this again on our YouTube channel, and we want you all to stay safe. In Nova Scotia, you know that means doubly safe. All right, so thank you again for joining us.
Everyone, and
do take care.
Thank you very much.
Thank you, everyone.
Okay,
Thank you for having us. All the best. Bye-bye.
Bye now.
Good night.
Thank you, Dr. David.
All right, you're welcome.
How you
Take
doing,
care.
sir?
Doing well, man. Doing well.
All
Take
right,
care.
everybody from Hadam say thank you.
Yeah, all right, good.
All right.
I need to
We'll
talk
get this
to
Oh,
you.
I didn't have my video on.
We need to
Sorry,
talk.
guys. Excellent
Oh,
presentation.
Benedict, how you doing?
I'm good, Mr. President. How are you? I didn't realize I didn't have my video on.
Oh, it's so busy out there that sometimes you just forget to put on.
Bye, guys.
It
Thank
is.
you so much,
Bye-bye.
guys.
Okay,
Thank you so
Lydia
much.
Joy,
We'll send
take
this to the
care.
community
Great
and
to
make
meet
them
you.
aware
Good
of
to
it.
see you, Mr. President. How are things at Adam?
Going good, going good. Thank you so much. All right, have a wonderful night, guys.
Okay, good
We're
night.
done.
Good night.
Thank you.
Yeah.
Thank you, everyone. Great job, Hawk.
Thank you, Carla.
Thank you,
All
Bernadette.
right. Bye-bye.
You
Thank
all.
you. You're gonna close out the meeting, David? I can get off? Oh, I thought he was saying he had to stay and talk.
I was just hanging out to be with you, Carla. Just to make sure we don't that we're still here at the end.
Yeah, I didn't want to do that either. I didn't want to kick anybody out.
And Dr. Miller's still with us.
Yeah, and they might have just forgot to leave the meeting.
Yes, okay. Well, then I guess we'll leave it at that. Dear
right.
Carla, thank you so much. I think it was a really good effort.
I do
think
too.
we
It was a
did
good meeting.
did it. Yeah. All right.
All right, have a good night.